start with some introductions.
Welcome, everyone. My name is Christine Cole, and I work with Kiki here at the Healthcare Authority, focusing on infant and early childhood mental health. And I'll hand it back to Kiki.
Hey, everybody. I am Kiki Fabian, also work at the Healthcare Authority with Christine on infant and early childhood mental health. And the other person we have today with us is Genevieve de la Cruz. And I'm just sharing that for this next slide, where we're going to get into a little bit of housekeeping. You'll notice that you have been automatically muted, and that's just to prevent background noise. You can come off of mute when we have our question and answer section. If you do have questions during the webinar, you can put them in the chat box, which is at the bottom of your screen. If you have a technical issue, this slide says to chat me. You can do that, but you'll probably get an answer faster if you send a chat to Genevieve de la Cruz, because she's here to offer us administrative support today. If you are hard of hearing or need closed captions for any reason, you can enable them with the Show Captions button at the bottom of your screen. You can use the raised hand reaction in this kind of reactions emoji section if you have any questions, or you can use the other emojis if you want to show a reaction to anything we're sharing on the screen today. And the last piece to share is that you'll see this little star icon that says new when we have content that's been updated since our last billing webinar. These billing webinars we offer about every 6 months, and most of the time the content is exactly the same, but we are trying to work on continuously improving our guidance and clarifying things. So when we have changed things, we use this little icon to show you what has changed. The last thing I'll share is we'd love to hear from you about who you are, what your role is, how you're involved in this work. And so if you wouldn't mind sharing in the chat your name, the organization you work at, what's your role, and any questions or things you're hoping to get from today's webinar, that will help us make sure we get to know you as well. Before we dive into
thing is that folks are asking if you could speak a little bit louder. So all that was asking, just so you know.
Okay, thank you. That is helpful. Is it any better if I hold this microphone closer to my face? Okay, great. Okay, and let me see if I can get my chat on my screen too. Okay, perfect. Okay. All right, so before we get started with going over the billing details, we like to start off with just an orientation to Apple Health or Medicaid in Washington State. Our Apple Health behavioral health system is a multi-system network of providers and services. It's governed by different authorities, so a lot of the work that has to do with Medicaid is overseen by us at the Healthcare Authority, but our friends and partners at the Department of Health have a big role to play too, because they oversee all the licensure and credentialing for mental health providers. Mental health services and behavioral health services are also funded by different funding streams. So we have state funding, we have federal Medicaid funding, we have federal block grant funding. And so that adds complications to understanding how to bill what, for whom, why, when. And we also want to acknowledge there have been many changes over the past decade when it comes to the rules, the requirements, the setup for a behavioral health system. Usually these rules are intended to make things better, to improve care, to reduce administrative burden for providers, but they always introduce new complexity, and it can be hard to keep up with things. So if there's anything that you hear today that you're like, wow, that's new, or that's a surprise, know that you're not alone. Whoops, went too fast. We also like to touch on one key part of this system, which is the difference between managed care and fee-for-service. So fee-for-service is also known as Apple Health coverage without a managed care plan. In this setup, HCA pays providers directly for each service that they provide. On the other hand, we have managed care, which for this population, children younger than 5, about 95% of those kids are enrolled in one of our 5 managed care plans. The goal of managed care is to create a delivery system that helps manage costs, utilization, and quality. And what it means is that there's an arrangement between the healthcare authority and each of these managed care organizations that accepts a set per member per month capitation payment. The thing that's important for providers and billers to know is that the guidance that comes from HCA kind of sets the ground floor for our fee-for-service program, but then each of the MCOs in turn has their own policies and procedures that are kind of based off of HCA's, but may add additional detail or additional steps. And so it's important to take into account what we share here today, but then to also go back to the MCOs and understand that there's any differences there. The other thing I'll add on this slide is that I'm realizing that we have not replaced AmeriGroup's logo with WellPoint, so they have had a name change, and so we will make sure to replace that for our next slide deck. Anything else on this section I've missed, Christine?
I was just thinking the same thing and made a note about the MCO plan.
Perfect. All right, let's dive into an introduction to mental health assessment for young children, which we like to affectionately call MHAYC here because we love acronyms in government work. So epidemiological research suggests that about 1 in 5 or 20% of young children will have a diagnosable emotional, relational, or behavioral health condition. Fortunately, these conditions, if they're diagnosed with developmentally appropriate criteria, can be really effectively treated and help return the child and their family to their kind of normal developmental path. Unfortunately, what we know is that our existing behavioral health system is really developed historically for adults and then kind of brought down lower and lower to think about younger adults, youth, children, but it often doesn't align with the unique developmental and relational experiences, strengths, needs of infants and very young children. And so all of that kind of lays the groundwork for why we might see things differently when we're working with young children versus older children, youth, and adults. One of the key things that is different is what diagnostic manual to use. So many mental health providers are most familiar with the DSM, or the Diagnostic and Statistical Manual. But really that manual is designed for children older than 5. And so when we're looking at kids younger than 6, the best practice is to use what's called the DC 0 to 5, which stands for the Diagnostic Classification, Mental Health, and Developmental Disorders of Infancy and Early Childhood. In many ways, it's similar to the DSM in that it outlines different mental health conditions and the diagnostic criteria for them, but there are a few key differences. One is that the DC 0 to 5 still keeps a multi-axial system, and the goal of this system is to really make sure that providers, teams are getting a whole person, whole family perspective of the child and family they're working with before diagnosing a condition. So making sure to look at everything in the lens of culture and community, looking at the child's development, life circumstances, medical conditions, relationships, which is a really key part of this work, looking at the caregiver-child relationship before diving into diagnosing a mental health condition. The other thing that's different for the DC 0 to 5 is that it includes developmentally specific criteria for mental health disorders. So like depression is in the DSM and the DC 0 to 5, but the criteria are specifically adjusted to be developmentally appropriate for what depression looks like for a 3-year-old. In addition, there's other mental health disorders in the DC 0 to 5 that don't show up in the DSM because we really only see them in young children. So excessive crying disorder, overactivity disorder of toddlerhood, those are just some examples. We'll get a little bit more into the resources that are available for folks to start using the DC 0 to 5, but we just wanted to give you a sneak peek into why we might need changes in our Apple Health system to make sure that providers can provide these developmentally appropriate assessments for young kiddos. Anything to add here before I turn it over to you, Christine?
Nope, that sounds good. So all of that background really informs work that happened across Washington State to update our policies in mental health, which we lovingly call MHAYC, or Mental Health Assessment for Young Children. And this slide is just highlighting the legislative changes that were made, which directed us to have our mental health assessments when we're providing them for children birth through age 5, when these are kiddos enrolled in Apple Health Medicaid, that folks can have multiple assessment sessions to reimburse for travel to home and community settings, and then requiring the use of the DC 0 to 5. We've captured here the definition of assessment through our WACs, or our Washington Administrative Code, just to help folks to know what we're talking about when we're referencing these multi-session assessments. Kiki and I have laid out the next few slides to dive a little bit deeper into why these assessments are needed and to go into how each of these pieces might be applied for you in your setting. Kiki, anything you'd add to this one?
I don't think so, but thank you, Lorenzo, that you're still having trouble hearing me. So I'm going to try to do a better job of keeping this real close to my face.
Awesome. Next slide, Kiki. So when we talk about assessments, again, we had that definition there, but we wanted to highlight that some of the common elements that are often captured for assessments, regardless of your age, are similar to the different aspects that Kiki was talking about for the DC 0 to 5. It's just that they're not always one-to-one in terms of thinking about the same terminology, but there's a lot of alignment, and that this is just highlighting that when we're talking about assessments, the reason that we're asking for all this information about needs and strengths or family and caregiving environment, development, this is all used to help us to determine whether or not a child or any individual might meet what's called medical necessity. And so this is a process that is done prior to starting services to help folks to understand what is the condition that's needing to be addressed, what would be the appropriate services that would help address that condition, and who's the appropriate provider type. And so our assessments help us gather all of the information to inform kind of those questions. And that's what helps us reach a diagnosis, which is usually the way that we indicate what condition it is that we think we're addressing through services. Within our Apple Health system, we typically expect that the ICD-10 ranges, the F01 to 09, and then the F20 to 99 codes are typically the ones that we see used for indicating that there might be a mental health disorder that is requiring mental health intervention. When it comes to children that are under the age of 6, with our new policies around this topic, we have created an Apple Health DC 0 to 5 crosswalk, which we'll give you a quick snapshot of later in the presentation. And that this gives additional guidance because not all of the codes that are used for adults were the best fit for conditions for young children. And so we'll talk a little bit more about that later, but we just wanted to give you a sneak peek that there are some differences and additional tools and resources when we're identifying the appropriate codes for these kiddos. Next slide, please. We also wanted to touch briefly on who are qualified professionals for providing mental health services in Washington State. This work is overseen by the Department of Health as they're our administrator for licensure, certification, and registration. And so they hold the role of kind of defining and overseeing scope of practice. In our Medicaid system, we often align with the Department of Health and their licensing guidance. And in Medicaid, we have two primary buckets that folks would be qualified mental health professionals. One is folks who are just independently licensed mental health providers. So this might be a licensed independent clinical social worker, a licensed marriage and family therapist, folks who have their own license that they're practicing. And then we also have mental health professionals that are housed under licensed behavioral health agencies. So these are organizations who also have a licensure, but there's a broader scope of providers that are allowable within those settings, as you'll see here. And so we're going to talk more about the application of this policy for these two groups as we go through the presentation, but these are the folks who we're meaning when we're talking about mental health professionals. Next slide, please.
And I'll just add, we have a little asterisk on this slide around the agency affiliated counselor with mental health professional attestation, because that provider type is currently undergoing rule writing to kind of create different levels and categories of agency affiliated counselors, some of which will have mental health diagnosis and assessment within their scope of practice, and some won't. That will be updated this summer. And so the next time we do this presentation, we'll actually have a little change here to note that change in licensure and credentialing.
All right, so we're going to dive deeper into the application of the multi-session assessment. And so on the next slide, you'll see this is the language that is from the proviso, not the proviso, the bill. And it just says that for Apple Health Medicaid, when folks are providing these assessments for children birth up through age 5, that providers are eligible for reimbursement for up to 5 sessions. You'll note here that we also have per client, per billing provider, per calendar year. This is funny language that we use in Apple Health Medicaid rules. That just means that this applies for an individual client, for the provider. So if you go to a new provider because you moved, this process starts over, and that it also is time bound by the calendar year. And all of this is without prior authorization. So you do not need to ask for prior authorization to access those up to 5 sessions. They're already available for folks. I think the other piece that I'll just note before we go to the next slide, sorry, Kiki, is that this is not requiring that folks have to have 5 sessions. This is optional. So for some families, a provider might see the kiddo 3 times to complete the necessary information to determine a diagnosis. For other families, it might be longer. So this is not requiring folks to use all of those 5 sessions. It's just creating the flexibility to allow providers the time to gather all of that information and those components that Kiki highlighted on that DC 0 to 5 slide. Thanks, Kiki. Next slide. When it comes to billing, we have lots of billing folks here today, so glad to see all of you. HCA does publish billing guides that are available on our webpage. We always recommend that folks continue to connect with your managed care organizations because sometimes they've added additional guidance and language to their guidance that they offer to their contracted providers. But when you look at the billing guides, they align well with those qualified professionals that we had talked about. So the green, that's here, the Mental Health Billing Guide Part 1. This is the guide that's most often used by folks who are independently licensed mental health providers. And for those folks, when they want to use this multiple session reimbursement policy, they'll use the same codes that they already use, the 90791 or 90792, and you just use it for each of the sessions. So if you had 3 sessions, each of the 3 sessions would use that code, and that's it. For folks that are working out of licensed behavioral health agencies, these folks are most often using the service encounter reporting instructions, or they might be using the Mental Health Billing Guide Part 2. So these blue boxes here. Unfortunately, they're slightly different, the guidance for which one. So if you are a user of the Mental Health Billing Guide Part 2, you'll do the same thing that we said for the Mental Health Billing Guide Part 1, but you also might be using the H0031. So for as many sessions as you use, you'll just use those codes each time. The difference for our Siri users is that you're actually going to use the 53 modifier on the sessions that you are providing until you get to the last session. You will no longer use the modifier so that you can tell us, I'm not going to need any more sessions. This is my last one. I have the information I need. So again, it's a little bit different depending on which one you use. But for folks that are mental health billing guide, use the same codes you always use, as many up to those 5 sessions that you might be using. For Siri, you're going to use the modifier for your initial sessions, and then the last session you take it off to tell us you have what you need. We always encourage folks to follow the CPT coding guidance. And so again, glad we have a lot of billing providers here that can work with your teams to make sure that folks are having what they need in their documentation and all that good stuff. Kiki, anything you'd add for this one before we keep going?
Not necessarily, but we do have a question from Lorenzo about kind of going over the provider types and the billing guide. So I'm going to quickly go back to that slide about provider types so you can see the color coding. Let's see. Oh, here it is. Okay. And then I'll turn it back to you to kind of re-say that again.
Yeah. So the green here is independently licensed mental health providers. So these might be folks who are billing Medicaid, but they're like in private practice, or they work at a pediatric clinic, or they're a part of a multidisciplinary team, and they're not housed within a licensed behavioral health agency typically. Then we have our blue here, which is for mental health professionals that are in licensed behavioral health agencies, which is a specific credential type for behavioral health agencies that are meeting the requirements for the Department of Health to get that special credential. And Kiki, is there anything else you'd add to those ones about my description?
I don't think so. Just that, you know, as Christine shared, like we have these different billing guides and we color coordinate. Like, usually people who are working under their own licensure are using this billing guide part 2. Usually people who are working at licensed behavioral health agencies are using the part 1 or series. But it's not always so easy. There's many different situations we have set up in our complex behavioral health system. So what we always recommend is to go back either to your organizational leadership, or if you are the organizational leadership, go back to your core provider agreement with the healthcare authority and look at, okay, what guide am I tasked with using? And or look at your contracts with the managed care organizations, which should outline, okay, which guide am I using? So we can't necessarily tell you which one you're using, but we do want to highlight that there is slightly different guidance depending on the one that you're supposed to use. Okay, looks like that helped answer Lorenzo's question. Anything else that you would add, Christine?
Nope, I think that's good.
It's a great question. I'd say it's probably one of the most common ones we get. So it's a good one to go over.
And on our next slide, for situations where you maybe need more than the 5 sessions, or that there might be a kiddo that started services when they were 5 and through the assessment process, they had a birthday and they're now 6. Limitation extensions are a form of prior authorization that you can submit to the healthcare authority or to managed care organizations to say, we are requesting medically necessary services to finish our assessment process. And so this is just to say you'll use that form to say either I did my first 2 sessions with this little friend and they turned 6 and I need to do at least 1 more session to get the information I need. Or, you know, there might be situations where a family, you met with them, they left treatment and then they came back to see you again later in the year. And so you need additional sessions. The last piece that we also wanted to just note, for folks that are older than the age of 6, limitation extensions are required to offer more than 1 mental health assessment session. So these up to 5 sessions are only available for kiddos birth to 5. And we recognize that there might be situations where other clients that are older than that might need more sessions. And so we would also encourage you to use this tool if needed. Next slide. We also had historically gotten a lot of questions about this, but when it comes to working with young children, a critical component to providing care is also understanding their caregivers' functioning and capacity to support them and their perspectives. And sometimes there are things that may not be appropriate to discuss in front of a child, or having the child present might actually inhibit your ability to be able to get the information you need. And so this is just highlighting that you are allowed to have caregiver-only sessions, with the caveat that it still needs to be informing the assessment for the young child. So it's still focused on understanding the child's history or the family's history, their cultural background, their situation, and evaluation of that caregiver or parent's psychological functioning to inform your understanding. And this goes back to the DC 0 to 5 slide again, which one of the axes it talks about is the quality of caregiver relationships. And so this information can sometimes be helpful in making determinations about that piece. Next slide, Kiki. We also wanted to highlight that when it comes to reporting a diagnosis, when you're going through that multi-session process, that we often get questions to say, well, I don't know what is going on yet, so what should I put down? We always want to highlight that folks should still be reporting diagnoses that are within their scope of practice. So if you are someone who said, this is not in my scope of practice, then you still should not be reporting that on your claims. Only things that you are appropriate to be diagnosing. Federal Medicaid requires the use of ICD-10 codes, which we talked about. And for those initial sessions, you'll actually use an F99 ICD-10 code. And that's basically saying, I don't know what's going on yet, but it's telling us that you are providing you are assessing for a mental health disorder and you're just in the process. When you get to your last session, regardless if it's the 3rd session or the 5th session, you should update that diagnostic code to be the most specific code. And so the DC 0 to 5 crosswalk that we'll go over helps to identify the different codes that would be appropriate. And so you'll use one of those codes and update on that final session. Sometimes a mental health assessment does not result in a mental health diagnosis. So the purpose of the assessment is to determine whether or not there might be a diagnosis. And sometimes providers might say, actually, after I've done my assessment, I'm concerned that there's a sensory processing disorder, or I think that there might be medical needs. And so I'm going to refer out to other services. And these cases, you can use this Z03.89 code to say that you were meeting to assess for a suspected condition, but that you did not result in a mental health diagnosis. We're going to talk more about diagnosis later on in this presentation, but we found that offering this information here often is helpful because folks are kind of trying to say, what do we do during the process? And so wanted to just make sure we shared this here. I think that's all we have for the assessment sessions right now, Kiki, if you want to jump into travel.
Awesome. So let's talk about provider travel. So here's what we've got going on for provider travel. When you're providing a mental health assessment to a child ages birth through age 5, providers are eligible for reimbursement currently for mileage costs for travel to home and community settings. And we didn't touch on this as much in our beginning part, but the reason for this is that for assessing young children and their families, best practice is often to do that in a natural environment, so a place where the child is used to their toys, they're used to the setting, the family feels comfortable, because that really allows mental health provider to get a good sense of what does a typical behavior, typical emotions, typical regulation look like. Young kids can be really sensitive to novelty, and so when they're in a new office setting, sometimes their behavior might look totally different, which is harder then for the provider to understand what's really going on. To get into the details of how to obtain reimbursement, the important thing to remember here is that this is a pretty restricted pot of money. It's really only allocated for very specific services. So you've got to have the right service code, you've got to be doing a mental health assessment, it's got to be the right age client, so the child has to be younger than age 6. And the way that we tell if the assessment is taking place in a natural environment, home and community setting, is by looking at a place of service code. So if you're not a biller, you might not be as familiar with these, but every claim is going to have this place of service code on it that tells you where it took place. And so certain codes that we've got kind of turned on for school, homeless shelter, home, or other place of service are the ones that are going to make a claim kind of eligible for this reimbursement. The reimbursement rate is based on OFM, or Office of Financial Management's mileage rates. And the process looks a little different for our fee-for-service versus our managed care. So if you're serving a client who's enrolled in fee-for-service, you're going to submit this invoice, which government ease for that is called an A-19. Submit this invoice directly to the healthcare authority. If it's for a client enrolled in managed care, again, you're going to want to go back to the policies of your managed care organization for that, but that reimbursement form is going to be submitted directly to the managed care organization, and that's where your reimbursement will come from. On this next slide, we have an example of what this form looks like. So you'll see the sort of information that needs to be provided in order to get reimbursed. This is really to help make sure that when we're reimbursing people, we're reimbursing them accurately, and we have some accountability measures to make sure that we are reimbursing people who are actually traveling. The example that we have shared on the screen is the fee-for-service form, the one that HCA reimburses directly. But the good news is that each managed care organization agreed to use the same form. So even though we don't produce those forms, they took our template and each of them is using the same form. So if you're working with a managed care organization, the form is going to look very similar. Anything else you think we should add, Christine, about travel at this point? Okay. If you have any questions about travel, I know this section was kind of quick, please feel free to put them in the chat and we can always come back. Now we're going to dig a little bit more into the last section of this work, which is the DC 0 to 5 requirement. So the language in the legislation states that Apple Health mental health professionals who are conducting a mental health assessment for young children are required to use the DC 0 to 5, which we talked about earlier, is that diagnostic manual. One question we get a lot is, what does this requirement mean? So this is kind of a new graphic to demonstrate the same information that we've been sharing, that we start with our legislation. That's, the law that was passed by the state legislature to make this requirement. And we want to look at the intent of it. What did the legislators hope that this would do? And the hope is really to support the mental health field in moving towards standard use of the DC 0 to 5 as that diagnostic manual. Then the legislation gets turned over to us at the healthcare authority to implement, or to kind of help spread out to providers. And so what we do right now to help implement this legislation is really to build workforce capacity. And we do this through a couple different things. One of the big ones is our DC 0 to 5 training initiative, as well as our Apple Health DC 0 to 5 crosswalk. We'll talk more about both of these in a second, but just so you know, these are the things that we're doing. In the future, we might respond to either legislative directives or workforce requests that might ask for additional implementation requirements and timelines. So sometimes we hear from people, oh, we wish there was more monitoring or more oversight of this. And we want to really wait until our full workforce and community is on board with that, and or we get a request from the legislature before moving into any sort of monitoring, program integrity oversight requirement. So just to recap, right now, the law is that folks are required to use it. There's no current monitoring or oversight process, and we're really focused on building workforce capacity. And who knows what the future will hold for what this looks like in the coming years. Hopefully we've explained this in a way that's clear, but we know this can be confusing for folks. So again, if you have questions, please feel free to put them in the chat. While you're thinking, we're going to kind of go over a little bit again of the resources that are intending to build workforce capacity. And we've kind of got two organizations that are really working on this right now, at a minimum. One is us at the Healthcare Authority. So we're responsible for this Apple Health clinical policy development and implementation. So what are the rules? What are the billing guidelines? What are the policies that Apple Health has around use of the DC 0 to 5? And then also, what resources do we develop to support both providers and billing staff in making sure they are meeting, following, getting reimbursed through these clinical policies? So one great example of that is the Apple Health Crosswalk that Christine is going to talk a little bit more about in a few slides. On the other hand, when it comes to our training for mental health professionals and allied providers on the DC 0 to 5, this is actually coordinated through our contractors, the Washington Association for Infant Mental Health. It's going through a little bit of a name change. I think they're now going to be called the Center for Early Relational Health. Is that right, Christine? Or something like that. But they oversee the project, which we call the Infant Early Childhood Mental Health Workforce Collaborative. And they offer a number of different trainings and communities of practice and webinars to help providers gain their skills in using the DC 0 to 5. So you here at this training, you may have had staff at your agency go through either the clinical training or the overview training. And we really highly recommend that, every mental health professional who may be assessing or diagnosing a young child go through the clinical training, and really anyone who touches the lives of young children and families enrolled in Apple Health can go through that overview training that just provides kind of the basics of what the DC 0 to 5 is. They also offer other resources that are really intended to help providers put those skills into use. And so there's a lot of great things going on at their webpage. We highly recommend you check it out and share that information with your staff if they haven't already gone through the training. Anything else you'd add here, Christine, about resources?
I don't think so, Kiki. I think that piece that we'll highlight for folks in case you have questions later. Kiki and I often use your questions to actually update the different items that HCA develops, like the webinars and our other policy tools. And so please feel free to send questions, not just during our time today, but always feel free to email, because it helps us to do the continuous quality improvement that Kiki was mentioning, to make sure it actually helps and answers your questions and you don't have to keep coming to get your answers, but that the guidance is clear. So that's all.
All right, I'm going to turn it over to you for scope of practice.
So this slide, I think we put that, it's new. Some of the content on the slide is new, but we have been trying to incorporate this because, like we mentioned earlier, folks often ask questions about scope of practice. Scope of practice is a really complicated concept, if I'm going to be honest, because it's really not clear, is the truth of it. In our state, scope of practice is largely directed by the Department of Health in terms of their licensing and credentialing standards, but there's also like elements of professional associations and what kind of training and experience and education you have. And so scope of practice is not necessarily something that is completely black and white, but it's really based on you doing an evaluation of your own experiences and knowledge base and the support that you've had to know what the standards of care are for different types of services and diagnoses. We highlight this because when it comes to the DC 0 to 5, there are disorders that are considered developmental, not necessarily just mental health disorders. It's similar to the DSM, that there are some things in there. The DC 0 to 5 is even more broad in that it has sensory processing disorder as well as like neurodevelopmental. And some of these things might not be the most appropriate to be treated by a mental health professional. And we linked here a resource that we put together to help folks, not with a specific provider in your region, but to give ideas of when you have a kiddo that maybe has a sensory processing disorder, that's what it seems like is going on, but that's outside of your scope of practice, the types of providers that you could refer to for them to get assessed and to get support. So this is just to highlight that just because something is in the DC 0 to 5, we are not implying that that would be within someone's scope of practice, but that folks should really do their own kind of assessment of their training and background to make sure that it's appropriate. Anything to add, Kiki?
Oh, sorry. No, I think we're good.
Great. We also wanted to highlight that the DC 0 to 5 is a diagnostic manual, not a screening tool. We often get questions about trying to understand the difference of these two items. One of the pieces is that a diagnostic manual, like the DSM and DC 0 to 5, really is capturing a cluster of symptoms and presentations to help with saying, I think that this is the disorder that I'm seeing, and to help to kind of guide treatment planning and service intervention. Screening tools are more often structured in instruments. So it might like be a checklist. It might have you answering different questions. A common one that is used for early childhood is ages and stages questionnaires. And screening tools might be used to monitor typical development. It might be to kind of monitor symptoms. It might also be to say, like, we're trying to understand like where there's strengths and things are going well and where there might be more challenges. Screening tools can be used to help providers to understand if they maybe want to refer a family to get a full mental health assessment. Sometimes screening tools are used to help inform the assessment process. And sometimes it's used to say, like, are we seeing any changes over time? But screening tools by themselves are not enough to determine a diagnosis. You would still want, if you used a screening tool as a part of your assessment process, you would still want to do a full biopsychosocial assessment process to make sure that you're determining if, getting a full picture to determine if there's a diagnosis. We often get asked if there are specific screening tools that we require or recommend or encourage use for as a part of the DC 0 to 5 assessment process, and we do not at this time. folks are welcome to to go visit our webpage and look at our EPSDT billing guide, which does link to some different recommended screening tools that are used commonly across the lifespan. But we do not have screening tools that we specifically are saying you should use this or you shouldn't. We did also hear this throughout the summer when we did a statewide tour. And so we imagine that there might be opportunities in the future as folks continue to identify this as a shared need, but we'd want to do it in partnership with folks across the workforce rather than have it be directed by HCA. Kiki, anything else that you would want to add?
No, but I am having trouble finding the link for the EPSDT screening tools you mentioned, so I might ask you to find that link and put it in the chat eventually. But I will put the link to our statewide tour report in the chat. Awesome,
thanks, Kiki. The next piece is around clinical and service records. So really sometimes this is with an electronic health record, but folks often also say, like, where should I be putting things about the DC 0 to 5? And historically, the Department of Health had guidance that said that had language around including the DSM, but there was recent policy change in alignment with our policies here at HCA, so that folks weren't saying like, DOH is telling us to use the DSM, HCA is telling us to use the DC 0 to 5. DOH updated their policy to say, we are also aligning that when folks are working with young children and the DC 0 to 5 is the appropriate tool, you are able to use that rather than the DSM in your clinical records. We included here the other elements that are recommended or required for licensed behavioral health agencies in their clinical records when it comes to mental health assessment. And these pieces are still expected and standard for young children, though you'll note in the blue, it now does say you might use the DC 0 to 5 or the DSM based on what's appropriate. Next slide, Kiki. We are finally talking more about the DC 0 to 5 crosswalk. The crosswalk is a reference tool. It's basically a way to say, this is what I'm seeing in the DC 0 to 5 manual. How does that translate into an ICD diagnostic code, which is typically used by different insurance providers to help communicate to say, this is the condition that I am treating with whatever code you're submitting. There is a crosswalk already within the DC 0 to 5 manual, though it is not state specific. Because states often update which codes are turned on or allowable in their state. And so the manual does not reflect what is currently allowable within Washington, and it has not been updated, nor is it updated on a regular basis. The reason that it's important to have something that takes the diagnosis and tells us how it goes to these other diagnostic codes is that the Centers for Medicare and Medicaid Services, which is our federal Medicaid agency, they require that an ICD-10 code is on our claims or encounters to be able to receive reimbursement. This aligns with common insurance practices nationally. In our crosswalk, we also have DSM diagnoses. And even though we are hoping that folks are moving towards using the DC 0 to 5 for young children, we also recognize that different electronic health record systems might already be set up to automatically populate or connect with DSM diagnoses, and that folks might not have a way to directly enter an ICD-10 code. And so for our crosswalk, we wanted to make sure that there were still DSM diagnoses in the crosswalk to help folks to be able to make that transition in their systems if their systems are not able to have the ICD-10 codes. And we also know it can take time to update EHRs and that it can cost money. And so it's just there to help be a tool for folks to be able to share what they're seeing, even if it doesn't fit perfectly for their electronic system. We also wanted to include a quick snapshot of how to use the DC 0 to 5 crosswalk. The first piece is folks will just do their mental health assessment. You don't need to look at the crosswalk until your assessment is complete. So folks will do their mental health assessment. They can look in their DC 0 to 5 manual to look at the different symptoms and to come to their clinical conceptualization of what they think is going on. And so for a kiddo that maybe you complete your assessment and you say, yep, it looks like we might be working with separation anxiety disorder, you then can go into the crosswalk and they are grouped by different families. So anxiety disorders are grouped together, mood disorders are grouped together. Once you get to that section, on the far left side, that's the DC 0 to 5 diagnoses. When you move over to the right, the first diagnoses you will see is the DSM diagnosis and the code. And then if you go all the way to the right, that's the ICD-10 code. We know also that sometimes the DSM diagnosis that we have put here and the ICD-10 classification that we have here, they might not be what the DSM has crosswalked in their manual. And that's because we chose what was the most appropriate fit for the DC 0 to 5 disorders. And so we recognize that might not all match for your DSM. Again, the DSM one is just here if that's a requirement or a limitation of your electronic health record. Our recommendation, if possible, is to crosswalk over to the ICD classification. Anything you'd add, Kiki? Awesome. We do want to note that we have something that is a little different and maybe has caused some confusion for folks, though we typically do say that we're looking at the F code series when it comes to mental health diagnoses. There are two different sections of our crosswalk that have Z codes. And this is for our sleep onset disorder and for relationship specific disorder of infancy and early childhood. These were included because there was not an appropriate code within the F code series that felt representative of what these diagnoses look like for young children. And we did not want to misdiagnose or have misinformation. And so that is why we went through the process to get approval to use these codes. So in these instances, if a child meets criteria for these disorders, it is allowable to use these Z codes as indicating a mental health diagnosis that is requiring mental health services. We still encourage folks to think about the standard and acceptable clinical practices, as that is the other element, and what is within someone's scope of practice. And so when it comes to sleep onset disorder in particular, like if that is something that is outside of your scope or that you do not feel qualified to provide services for, we still wouldn't say, well, just do it because it's within the crosswalk. So again, all of those pieces going together of what is the disorder that we're seeing, what are the appropriate services to treat that disorder, and who are the qualified professionals, and hopefully folks are reflecting on what their scope of practice is. But this is just to clarify that you can use these Z codes if they are what you are assessing for and what you've arrived at for kids birth to 5. These are not allowable for kids over the age of 5. This is only for this policy. I think that's Kiki. Anything else?
I'll just add one thing, like another complication to this is that they're not allowable as the principal or the primary diagnosis to meet medical necessity for kids older than 6. But some of these Z codes, especially these parent-child conflict ones, are sometimes used as secondary diagnoses to just say, okay, I'm seeing a kid for anxiety disorder, but I've also noticed in working with this family that there is some conflict going on. That's not what I'm treating the family for, but I see that in my practice and I'm documenting that kind of as like a history or environment or circumstance. So you're still allowed to use Z codes as secondary diagnoses for kids older than 6. You just can't use them as the principal or the primary diagnosis to meet medical necessity criteria. And I see that Nicole has a question and says, please confirm if F99 is required to be primary in these instances. We utilize Siri, and MCOs have denied charges when a Z code is primary on the claim. So I think this question would really depend on the age of the child that you're serving. If they are younger than 6 and there is a diagnosed relationship-specific disorder, our guidance from Apple Health would be that one of these Z codes should be the primary on the claim. Older than 6, it's a different story. Anything you'd add, Christine?
I would just say that for Nicole and others, if you go back and you say this is for a kiddo under the age of 5, and that we are using these codes. So it's not opening all Z codes, it's these specific codes for sleep onset disorder or relationship specific disorder. We can provide our managed care email inbox that we can sometimes resolve like issues when they come up. We always encourage folks to reach out to their managed care organization first, just to see if you can resolve it. But if you look back at where you're getting denials, we can put the managed care inbox that you can let our team know, and we can follow up to make sure that we clarify if there's any misunderstandings with the plan. Awesome, thanks, Nicole.
Yeah, great question.
Is this still me, Kiki, or is this back to you?
Oh, I'll take it.
You go ahead.
So, so you're here. You did the billing webinar. Maybe your staff have gone through the DC 0 to 5 training. Now what? Unfortunately/fortunately, implementing something new like the DC 0 to 5, the MHAYC work could involve a lot of different steps. You know, when we went around the state and talked to mental health providers around what does it look like to implement, the kind of checklist that we have here on the screen are just some of the things that folks said had to be changed in order to get this off the ground. So staffing, scheduling, workflows, how to talk with parents about this, your assessment questions and procedures, electronic health records, screening tools, provider travel. Ooh, it can be a lot. And so what we're excited to share next year is an upcoming series to hear from providers like you about how they're making these changes. So if you're feeling anxious or unsure or not sure how to get started, this is for you. We're really excited to be offering this. We don't have our date set yet, and so what we would encourage folks to do is to sign up for our email updates, so you'll be the first to know when these sessions are scheduled and when you can register. Some of the folks who might be sharing might even be on this call today, so look out for that. And this is really thanks to the feedback and the things that were shared through our statewide tour. So big round of applause to all the folks who participated in that. Anything you'd add about this series, Christine? Last but not least, if you are not tired of hearing from us yet, if you want to hear more, there are a lot of different ways to connect with us. Like Christine said, we love to get emails from folks. So our emails are linked on these slides that we'll be sending out to you. We can put them in the chat. We have 2 different web pages. Well, we have actually more web pages, but we've got 2 different primary web pages now. One that's really about all sorts of billing, providing mental health services for young kids. One that's got all the details about MHAYC and the assessment process. The slides and the recording for today will be on that MHAYC webpage under billing. We've put that link in the chat to sign up for email updates. And then the last thing is that we do often offer office hours. Office hours are kind of like an informal way to drop in and ask any questions that you might have. Our next office hours are coming up on April 25th, I believe. We'll make sure we get the right date to you. And the best way to sign up for those is to go to our webpage and just click the link to join. They are very informal. We often spend the first, 5 to 10 minutes kind of going over some updates or background. And then the rest of the time is really just to hear from you what's going on and see where we can troubleshoot. So those are all the many different ways that you can connect with us. And I think that's all we have for today. But before we stop recording, let me just turn it over to Christine to see if there's anything else she wants to add.
I don't think so. Thanks everyone for joining us. We will certainly pause for questions, but we hope that this is helpful. And again, please share any questions that come up for you even after today so that we can make sure that this content stays relevant for you and your teams.
Awesome. Well, Jen, you can go ahead and stop the recording.